Announce to introduce our guest, who is I won't say old friend, I'll say longtime friend and colleague of mine from the informatics world. So those of you who are trainees, this will be you guys in like 20, 30 years.
Right.
We won't reminisce old Navy war stories or anything. Anyways, I'm pleased to introduce Dr. Danny Sands from Boston, Massachusetts, who is a primary care internist at Beth Israel Deaconess Medical Center and also has an academic appointment at Harvard Medical School. He is a tried and true informatician. He makes extensive use of health IT in his practice. And in addition to practicing, he's currently the chief medical officer of, I don't know how to pronounce it.
Wicked Smart.
Wicked Smart.
Wicked Smart.
Okay. And he's also co-founder of and chief advocacy officer for the Society for Participating Medicine, which is why he is in town organizing an event tomorrow that DMICE is a co-sponsor of. And there's still tickets available if anyone wants to go.
It's going to be a cool event. I'm not giving the same talk, so.
And it takes place tomorrow from 8 a.m. to 1 p.m. and will be, what's the title of it? I have it on here somewhere.
Advancing health equity through participatory medicine.
Great. Anyway, so just to not take too much of Dr. Sands' time, he is originally a graduate of Brown University, where he got a Bachelor of Science in Biology and Medicine in 1984, attended the Ohio State College of Medicine, graduating in 1988, did a residency at Boston City Hospital in internal medicine, and then an MPH at the Harvard T.H. Chan School of Public Health. And has done a number of things that I won't continue to read on because I don't want to take too much time of his talk.
All right. Thank you very much, Bill. So I got a question. Do I have to be in front of this webcam in order to be projected over there?
They're not going to see you.
Yeah, they're just viewing your slides.
That's fine. That's good.
And
And
here's
is there a way to make that bigger so we don't have those people across the top?
No, that's the WebEx.
That's just, you have to do it.
Yeah.
Okay. All right.
And this is the microphone that picks you up right here. But you can stand over there.
Will it pick me up okay?
Yeah, it picks you up. Yeah, it's fine.
Okay.
You don't need to be
And is it possible to make the lights a little brighter?
brighter.
Is it okay? Or is that going to be too hard for you to see?
It depends. Let's try.
It is.
It's too hard to see?
Yeah.
Okay. We'll be more dark. But if you fall asleep, we'll come get you. No, I'm just kidding.
Okay.
It just feels dark. All right, so thanks for coming today. And for those of you on WebEx, I appreciate you coming virtually. I've entitled this talk that the future of healthcare is participatory, and it's about the importance of informatics as a supporting role. And this is what I want you to take away from this when we finish, okay? So let me start by saying something. Well, let me ask you a question. I can't see the hands of people who are remote, but of you here, how many of you are clinicians, healthcare professionals in some way? Okay, so a couple of you, yeah, all right. And do you still see patients?
Yeah.
Good. What's your area?
Well, right now I'm seeing ALS patients for mental health support, but I did internal medicine and psychiatry.
Wow, ALS patients.
Yeah.
Wow, okay, that's interesting. And Bill, I know about you. So I'm going to just point out some of the challenges we have with our healthcare system. Can I just get is there a way to get feedback from the people? I want to make sure they can hear me over there.
Yeah.
Out in WebEx.
Someone raised their hand.
Good. Okay, good. So I want to point out that we have a crisis of healthcare in this country, in the world globally, but particularly in this country. Although as I travel the world, many of these things persist. So some of these things are an epidemic of chronic diseases, an aging population everywhere in the world, patients with rising expectations as not just patients, but as actually healthcare consumers, as we say, which is a stupid word. Rising costs. In the U.S., we spend over a fifth of our GDP on healthcare, and we are proud to have the 35th best healthcare country in the system in the world for that. And we have an increased complexity with our system, not just on the medical side, but on the transition side. We have an increasing number of hands that touch patients. We have poor information exchange and coordination of care, and we have a lack of trust and declining patient satisfaction. And I'm only listing a few of the things that afflict our healthcare systems. But we still think about healthcare as if it is a traditional service industry. This is the way economists talk about it. This is the way almost everybody talks about it. So this is a problem because it is not just a typical service. If we think about it as a typical service, we're going to do it in injustice. Ideally, what should patient care be? And I would say to you that healthcare should be thought of as a collaboration around the patient's health. And that idea of that healthcare is a collaboration. And by the way, we talk about collaborations in healthcare all the time, but it's usually about teamwork and about, how the nurses and the doctors and techs and everybody talk to each other. But it's more than that. It's a collaboration between the patient and the healthcare professional. And collaboration applied to healthcare is participatory medicine. Now, how many of you collaborate in any aspect of your lives? Everybody does, right? I mean, you're either collaborating with people here in the department about research, or it might be a grant that you're doing. It might be raising children. It might be other various things. All kinds of things we collaborate around. So from, as Bill said, my many, many years of experience, I will tell you that I think there are 5 features that are common to successful collaborations. And before I go on, I should mention at least, this picture is really a patient of mine, but he's also a collaborator. And we are, I'll mention him again later. This is ePatient Dave. You can actually read more about him online. So that really is the office where I take care of him. Notice the antique computer screen we have there. We still have those antique computer screens in our offices. It's a nightmare. But anyhow, so successful collaboration. That's what I was getting to. So the first thing is open communication. Critical. So, we have all heard, you're not communicating. You're not communicating with me. You've got to tell me what's on your mind. So that's one thing. Another thing is sharing in decisions that you're making. A third thing is mutual respect and trust. Next, there's information sharing. And finally, engagement. Okay, it's engaging in the conversation, the discussion, and the collaboration. So those are 5 of the elements of successful collaboration I would submit to you. And let's think about how we could apply these to healthcare. But let's take a tech digression for just a minute. Okay, this is some data showing the rising use of the internet across different demographic groups. And I'm sorry, in this, the way this is projecting, you can't read it that well. But I'm going to orient you. We're looking at the years 2000 out to 2021, and the top bar there, that starts at about 70%, and now it's at almost 100%. That's people 18 to 29. No surprise, right? All these people are online. But what's, I think, more interesting is the bottom line, which are people 65 and up, where now we have almost 70% of these people online. And so that's a really important thing to keep in mind. The point is this cutting across all demographic groups. And by the way, if we look at this sort of sliced by race or ethnicity and so on, that's rising too. And although back when, 20 years ago, we were talking about, oh, it's the broadband access, that's the big problem, it's causing a digital divide, it's not so much anymore, because these devices, these handheld devices that we're carrying, have helped us leapfrog the digital divide in many situations. We still have a digital divide, don't get me wrong, but it's getting less. And this is happening all over the world, by the way. So the fact that we all have access to this information is fantastic, because this is allowing people, patients specifically, to connect to information, to caregivers, to healthcare, and to each other. And that has been quite dramatic. And that, in fact, has enabled so many of the things that you are working on and that we'll be talking about today. So this enables your world. Okay, not just your research, but your world, right? So think about your world. Think about the world we live in. And think about, I'm not going to ask you how old each of you is, but it is interesting to, the acceleration of technology, right? And how things have changed. I can tell you that I remember when my oldest daughter was 2 years old, and I showed her, Bill remembers these times, right? I showed her, I had this BlackBerry device, and all of a sudden the BlackBerry could not just do email, but it could connect to the web, right? And that was just magical, right? This is like 1995. And I thought this was amazing because there's no wires, right? There's no wires. I got this thing and it connects everywhere. I can get the world's information on it. And I showed it to my 2-year-old daughter. And she said, nah, it's too slow. She was 2. Anyhow, think about what's happened to the world technologically, right? This is the world we live in, okay? You got an Apple product, you got a PC, right? Airbnb, Amazon.com. When I'm speaking at conferences, sometimes I'll say, Amazon, right? What other service, in the US at least, can just almost know exactly what it is that you need and have it delivered to your door within a couple of days, or even the next day, even the same day. But it's, but it's so permeated our lives. So this is what I ask at conferences. I say, well, how many of you have ordered something on Amazon through this conference while you were sitting in the conference? And half the people's hands go up because you think of something and you make it happen. So this is how our expectations have changed, okay? I mean, nobody even thinks about taking a taxi anymore, right? We're taking Uber and Lyft all the time. It's just a magical thing. So is this how you experience healthcare when you're in the healthcare system as a patient or as a caregiver? I would argue that it's not, that we're not there yet. So let's talk a little bit about the online habits of US adults. I'll just give you a few facts. And admittedly, some of these are a little out of date, but they're still, I think they're still valid because I was tracking them and they get higher and higher all the time. So here, 80% of online adults have looked for health information online. 80%. And each day, more people search for health information than see one of us. Okay? That's remarkable. Okay, that's really remarkable. And more than half of those people act on the information they're finding online. Okay? And that's really interesting too, because when it comes to information that we tell patients, what proportion of the time do they act on the information that we give them? It's a low percent, maybe not a fair comparison, but I think just to put things in perspective, okay, patients don't often do what we ask them to do in the office. A third read about others' health experience online. I'll just go on to this. A quarter have tracked their own health information online. How many of you have tracked your health information online? We all have, actually, because you have one of these devices, and sort of by default, your information is being tracked online. You can choose to share it with other people or not. And people are using social media for health. So these are really dramatic things, and this is how people think about health and the internet. So there's this term that I use, that we use, people use, called e-patients. And so back a long time ago, at the dawn of the internet, when we realized that there are all these opportunities for patients to use the internet for health information, everything was e, okay? We talked about the work we did as e-health, for example. But the e for that is electronic. But the e-patient benefits from the online technologies. But the E here is about engagement. And the term e-patients came from a colleague and friend, deceased now, Tom Ferguson, who was the guy who who brought a bunch of people together who were trying to make healthcare different, building on these technologies. And this is the group that ultimately created the Society for Participatory Medicine. And he defined e-patients, and he said e-patients are engaged, equipped, empowered, educated, and enlightened. Okay, so that's what e-patients are about. It's not electronic. Electronic is just it's one of the layers of the network, let's say. So that's what it's about. So how can we foster collaboration with patients? I would say there are 3 areas that I want to focus on today as we talk about this. So it's information, convenience, and communication. And all of that is so that e-patients can play a greater role in their care. And in my mind, you may say, well, not everybody's an e-patient. Yes. I say everybody is not an e-patient. However, you're either an e-patient or you need to become an e-patient. You will become an e-patient, hopefully. Everybody is going to be in some level of transition to that role. So let's talk briefly about information. I'd say there are 3 types of information I want to talk about. Okay, type 1 information, as I define it, is general information. It's let's talk about diabetes, okay? What is diabetes? What happens in diabetes? How do people get sick with it? Why do people get sick with it? How do we follow it? What are the complications and so on? That's type 1 information. Type 2 information is information about my disease. I want to know what's going on with my diabetes. What's my hemoglobin A1C? What's my, am I having protein in my urine? What are doctors saying about me? This is my record information, okay? So that's what that is. Type 3 information is peer information support. It's information about other people like me, other people who have diabetes, and what have been their experiences, and what can they add. And these are orthogonal to one another. They're the same, but they're different, okay? You're not going to learn everything about your disease from just type 1 information, or even just type 2 information, but type 3 is really going to help you. I'm sorry, I have a duplicate in there. So on that type 3 information, peers, I love this quote from Pierre Lévy, who's a philosopher, a cultural theorist, and a media scholar at the University of Ottawa. And he wrote many years ago, in 1997, no one knows everything, everyone knows something. All knowledge resides in networks. And I know I'm talking to a technical audience, but he wasn't talking about technical networks, like computer networks. He was talking about networks of people. But it does apply to the computer network, of course, as well. So we have a shifting paradigm in healthcare because of the global access to information, type 1, type 2, and type 3 information, by the way. We have a shifting paradigm in healthcare. The traditional healthcare paradigm, and you still see it today, because we haven't made this transition yet, is information asymmetry. It's the physician is an oracle. The physician is the font of all knowledge. And physicians are very comfortable with this. But I would say, and I do say, that for physicians, it's kind of a burden. Because when I talk to groups of physicians, I say, okay, we're just among friends here, even though there are 1,000 people there, whatever. How many of you know everything there is to know about your field of medicine? And people have this uncomfortable laugh, right? Because they know that they can't know everything. So it's impossible for us to do this, but at the same time, we act as if we know everything. We act like the know-it-all that everybody hated in school, right? We act like that. And this is what we're comfortable with. But that's kind of living a lie. And we need to rethink that. And we have to rethink it because people have access to this information. We don't have a lock on knowledge anymore. So we need to move to information symmetry, where the physician and the patient are partners, and rather than feeling threatened about this, we should feel liberated by that. Because all of a sudden, we don't have to live this lie anymore. And we can go back to being healers again. I mean, we didn't go into healthcare because we wanted to be the know-it-all, at least most of us did. We really wanted to help people with our knowledge. And that's not about being a know-it-all. It's about the more human aspects of healthcare. One of our colleagues, Marge Benham-Hutchins, who is an informatics colleague in Texas, although she just recently retired, Marge, when I showed her this, she said, you know what, Danny, you're not talking about power asymmetry. And power asymmetry is a huge systemic issue that we have. And that is that, imagine the patient who walks into the hallowed halls of OHSU, right? And everything is clean and sparkly and white. And they just feel like they have to stay in their box as a patient and not question things. And they have to sort of respect the hierarchy. And that is a problem. And in fact, it's more of a problem for people of color or people who have been historically discriminated against, okay? Imagine African American coming to a place where almost everybody's white, except for the lower level staff, right? And that's not good, and that's going to make people even more uncomfortable and create more of a challenge, because power asymmetry is a big problem because we can't get things done. In the industrial world, okay, this leads to all kinds of problems that Toyota first famously identified. And in healthcare, this leads to problems too, and I'm not even talking about patients. If you look at what's the dynamics of surgical teams, for example, when people are afraid to raise their hand and say, hey, I think there's a problem here. That's why we have timeouts and things like that, and we're trying to change this culture in healthcare. But patients are part of this hierarchy, and we need to be more collaborative. So one of the things we can do as healthcare professionals is we can ask our patients, we're really good about asking patients, hey, do you smoke? And how much you drinking now, Bill? So we're good about patients asking patients that, and their sexual history and drugs and all this stuff, and you exercise. But we should be asking them too, where do they get their health information? Because we know from the previous data, that's going to change their behaviors. Because they're going to act on that information, and if they're not telling us about it, that's going to be a problem. Maybe that's why they're not taking their medicines. Maybe that's why they're not going to the specialist we referred them to. So by asking patients, that says to patients, oh, this guy's cool with it, or this woman's cool with it, this doctor's cool with it. The point is that now I'm not afraid about this. They say, some patients are worried, if I bring this up, my doctor's going to say, I don't want to hear about that stuff you read outside of my office, because I own that information. And that leads to honest disclosures, which is, of course, an important part of a trusting relationship. And we need transparency in every aspect of healthcare and society in general. I just was watching the news this morning as I was getting ready, and I understand that President Obama now is pushing a proposal to make sure that there are no hidden charges on any things that we, when we buy theater tickets or we, sign up, we make reservations at a hotel. No more hidden charges. It needs to be more transparent. Well, what about healthcare? Healthcare is the worst, right? You have no idea what things are going to cost when you go into the healthcare. You get a doctor's appointment, you get these bills, because all of us have a deductible. Gone are the days where you have like no deductible. So everyone's paying out of pocket. And I remember when my kids first got their own health insurance, they say, Dad, why am I having to pay, $500 for these lab tests? And I look at them, they didn't even need the lab tests, but nobody asked, right? So we need more transparency. And there's a number of things we need transparency in. We need transparency of data. So all the information about you, which now through federal regulation, and the society promoted this, data transparency is coming, it's here, it's going to get better. Charges, what are things going to cost? By the way, healthcare expenses, a leading cause of bankruptcy, the leading cause of bankruptcy in the US. That's ridiculous. And in other countries, so I've traveled a lot in China, there's a lot of healthcare is covered, but if you, God forbid, get diagnosed with cancer, this will actually bankrupt your entire family. That's how bad it is, because you can't get those medications paid for. And then there's quality, right? There's no transparency about quality. It's kind of absurd. If you come to me as a doctor and you have whatever problem, let's say you hurt your hip or something, and you need a procedure done, you need to see a specialist, you're going to say, who should I see? And I'm going to say, oh, see Dr. So-and-so. And then you should say, how do you know Dr. So-and-so is good? And I'll say, oh, because I've sent a lot of patients to her and nobody's complaining. Or, I play golf with her every once in a while and she seems like a nice person. We have no information about quality, about outcomes, right? Nor do we have information about satisfaction. So those are the things that I think we need more transparency in. How can we foster collaboration with patients? The next thing I want to talk about is communications. And so I'm going to mention a number of things that relate to communications here. I don't want to take too long, but we need multi-channel communication. We cannot just focus on the time we have in the office, and I'll come back to that later. We need to provide access, for example, to electronic messaging, like email, right, or secure messaging. And as Bill knows, I was an early pioneer in this space. I co-authored the very first guidelines on using email with patients in 1998. And still doctors say, oh, I'm not exchanging email with my patients. But it's huge. It improves access, it's more convenient, it avoids the tyranny of the urgent. Shared decision-making, another communications issue, leads to reduced anxiety, faster recovery, and improved adherence with and satisfaction to the care plan. We need to be culturally sensitive in our communications. We need to increase health equity and respect, which improves trust and adherence. And we need to have better EHR etiquette. And I think I have a slide about that I'm probably going to just skip through quickly. But how we use that EHR, and Bill over here, and me too, we were early pioneers in the use of EHRs in practices, right? And we had to fight upstream because our colleagues said, oh, I'm not bringing a computer into our offices. I'm sure Bill remembers this well. And we did this, right, in the early days. But what's happened now is that, first of all, EHRs are often often it's the doctors working for the EHR rather than the EHR working for the doctors, which is not the way we designed things many years ago. Secondly, we have still not really figured out how to appropriately use this technology in the offices. And there is a good way and a bad way to use this. I'll leave it at that. I'm going to skip through this in the interest of time, but there's some things that I reference a number of the features of electronic communication with patients. But it's really important. Patients benefit from this a lot, and doctors benefit from this a lot too, once they've embraced it. I mean, think about your life if you only had to talk to people on the phone or see people face to face. I know my kids who are now, in their late 20s, they never want to talk to people face to face. They only want to use electronic communication of various kinds, right? So we need to appreciate that fact. And it really is a way that we can take care of patients using this technology, because we're too busy. There's a huge line of patients waiting to see us. It takes months to get to see a doctor in many practices, unless it's an emergency room, right? So we need to fix those problems. And in mental health, as you know, it's even worse in most places. I assume that's true here too. Most places I've been to,
Yeah,
it's impossible to see a psychiatrist, and it's tough to see a therapist too. So there are guidelines about how to use electronic health records in the office. And since only one of you is currently using an EHR, I assume you're not, only one of you in the room is using an EHR now. I won't go through this, but when we distribute the slides, you can see this better. But there are rules, trust me. Practice this way, it's much better for patients and much better for the doctor. But I think the one thing I would take away from this is recognize that we need to be human in the office. That's why the acronym for the first part is human. We need to be human in the office. We need to respect that. We can't be always interacting with that computer and not connecting with our patient. The worst thing is we got this computer screen maybe usually turned away from the patient. They can't see what we're doing. And we're typing away, looking at the screen or a keyboard or both. And we're not looking at the patient. Literally this stuff happens. Patients saying, oh yeah, my husband beats me, and I tell you, how much does he beat you? And did you really get injured? This is the kind of stuff that goes on. We're losing compassion. We need to follow better rules about that, and we need to appreciate the fact that when we use an EHR, it's not just the patient and the doctor in the room. There is a third party, and we can't ignore it, and we can't pay too much attention to it. We need to make that part of the conversation, and that can be a useful part of the conversation. For example, the patient should be watching what you're doing on the screen. The patient should be able to look at their own data. Show, this is what happened when you stop taking your blood pressure medicine. Look at what happened to your blood pressure measurements, right? We can show them this information in the office, and that can be a very effective tool. I write my notes with the patients there using dictation, and patients love that, right? Transparency. All right, shared decision-making. Critically important, as I mentioned to you, there are rules for how you do shared decision-making. This acronym, which is SHARE, is from the Agency for Healthcare Research and Quality. And I won't go through with this audience, but I will tell you that we need to be doing a better job of this, because as I mentioned, this leads to improved satisfaction, patients following the plan because they co-develop the plan, and better outcomes. My slides are doing that. I said this. Next, let's talk about convenience. Okay, the third of those three areas that I want to talk about. So how many of you stand in line to withdraw money from your bank? I got to be honest with you, when I'm talking to people, and you may be some of those people, they say, wait, who would ever, that never happened, right? That's not a thing. But it is a thing. People used to do that. It's incredible to think about that today. Technology has totally changed that. Another example, how many of you make routine airline reservations by talking to a travel agent? No! That's a thing too, but the travel agencies are closing because we disintermediated them using technology. So why is healthcare so problematic? Because this is what happens when you call my office or your office. This is crazy, right? So we make it very difficult. We want patients to keep their appointments. We want patients to fill their medicines and blah, blah, blah. So this is a survey. This is a decade old, admittedly. But they ask patients people who had seen a doctor in the past year, so it's not like, you know, people who are 20 years old and haven't seen a doctor and don't understand, ask them, how many of these things would be important to you? Okay, making your appointments online, and it's over 50%. Making payments and seeing your bill online is 50%. Looking at costs online, sending email, it's all high proportions, right? And then they ask the same people, how many of you can do those today in your doctor's office? And not surprising, the bars are much lower. Now, because of federal regulation, I know that the bottom bar has moved up somewhat, but we're still challenged in some of these other areas. And again, the whole idea of technology, just what I showed you in the other slide, it can reduce barriers and it can reduce friction in these transactions. And don't we want patients to get their care? So this is a huge opportunity. I don't look at it as a failure. I look at it as an opportunity because I'm an optimist. All right, next topic. Would you like a visit with this healthcare? Okay, visits. So 2 axes on the board here. The horizontal axis is diagnose and treat on the left and prevent and maintain on the right. The vertical axis is physical resources at the bottom and virtual resources at the top. Where do we spend all of our time and attention and money in healthcare today in the US?
Bottom left.
Bottom left, right. Every time you see a chart like that, the answer is always we're starting in the bottom left, okay? And that's the most expensive quadrant, by the way. And in the upper right is the least expensive quadrant, but this is where we're focused right now. And if we move to the upper right, we get to change, upper right, we can change the horizontal axis to healthcare, moving from healthcare to health. Many people say we have a sick care system and not a healthcare system, or it's actually not really a system at all. And we move from physical resources and virtual resources to the hospital, to the home, and even everywhere, anywhere, at any time. And there are many things that are driving this, a lot of those things that we talked about earlier. So this is better for all stakeholders. And the best example of this, oh, sorry, I'm going to show you this first, sorry. This is an example of why this is important. Okay, this is a graphic that was designed by a designer who has Parkinson's disease. She lives in Sweden. Her name is Sarah Rigara. And Sarah put together this image, and let me just explain it to you. What looks like a big blue box is actually a lot of little blue dots. And each one of the dots in that box represents an hour in her life in a year. And there's one little tiny red dot way up in the top row. And this is a magnified image that you see in the middle. And she says to manage her Parkinson's disease, Sarah Rigara spends 1 hour in neurologic health care and 8,765 hours in self-care per year. Even our sickest patients, and I've done the math on this, patients who feel like they're in the hospital or the ER or some specialist office every freaking day, it seems like, I go through and I do the math, and they're still taking care of themselves in some way at home with their caregivers most of the time. So we need to appreciate this fact. Okay, health happens between visits. Parenthetically, I used to work for a company in the early days of that company that was based in Portland, interestingly enough, called Conversa Health. And we adopted this as our slogan for the company, our tagline for the company. Health happens between visits. The pandemic that we just went through has helped accelerate some of this thinking. Because all of a sudden we realized that we can't be bringing people to the office anymore. Just like you don't even bring people into your division anymore, your department anymore as much. And because this is happening to businesses, but it really happened to healthcare. It just wasn't safe. People didn't want to come in. We didn't want them here, right? So that helped accelerate this idea that back when I worked at Cisco, we were pushing this idea, and this is 12 years ago, okay? And we were pushing telehealth, and nobody was budging. But what happened in the pandemic is that all of a sudden there was reimbursement available for this. Always follow the money. So if any of you get out of your informatics careers and you want to go into business, okay, you got to follow that money. Think about who's going to pay for this innovation that you're developing. At any rate, Amwell, and I don't have any I shouldn't say that. I do have a connection with Amwell because Conversa Health got acquired by Amwell, so I am a shareholder of Amwell. But that's just an example. As you know, there are many companies that are doing telehealth right now, and there's a lot more telehealth taking place. And my patients have gotten used to this. They say, Dr. Sands, why do I have to come in to see you? I can just do a telemedicine visit with you. Yes, but you know, there are limitations. There are some things I can't do, right? Right? I won't graphically describe things we can't do, but there are many of them that we can't do that way. However, keep this in mind. We're going to come back to this as an important concept. So now, I'm going to flip over a little bit, and we're going to talk about those three things that patients need in order to be more engaged in their health. Now, I'm going to talk about participatory medicine a little bit. Okay? Participatory medicine, which I'm going to explain in a minute, is something that is fully supported by medical informatics. And this is a really important thing. Not that patients and doctors can't be collaborating and so on without, but the technology really is important support for this. And this is what I really want to spend the rest of my time talking about. So let me give you several examples of this that I think we should be thinking about. Okay? One is patient-generated health data. Patient-generated health data. So that means not data that comes out of the instruments at OHSU or what happens when we interact with you in the office, but this is stuff that you're doing on your own, right? And there are all kinds of different things that you might do on your own when you're at home or not in the office. Okay, it could be activity levels, it could be symptoms, it could be biometric data. Everyone always jumps to the biometric data because that's cool and sexy, right? And it is cool, right? But it's blood pressures, right? It's weights, it's pulses, it's glucose measurements. There's so much stuff, but there's even more, as we'll talk about in a minute. Medication effects, medication adherence, all that stuff is patient-generated health data. There are mobile applications, all this stuff. And this is from the Office of the National Coordinator for Health, IT. So all these different examples, there's quantitative, there's qualitative data. There is biometric data, there's self-testing data. So that's a really interesting thing too, right? Which is that, you know, it's been a long time now, right? Decades, right? Where people can do a pregnancy test at home, right? Okay, that's great. It's not even cool anymore, right? But what happened in the pandemic, right? All of a sudden, everybody's got these test kits. They're testing for COVID at home. And now there are way more COVID tests being done at home than there are being done in healthcare facilities. Okay, that's pretty dramatic, right? So there's a lot of testing that takes place. You can test for STIs, sexually transmitted infections, at home. You can test for HIV at home. You can test for all kinds of things. People are ordering their genomic panels at home. So it's really a great amount of stuff. Then the next issue is requested versus unrequested data. So let me tell you what I mean by that. Well, let's say we're following you hypothetically for high blood pressure. And so one example would be that I say, what's your name?
Umrish.
Omrish?
Umrish.
A-M-R-I.
A-M-R-I.
Got it. Umrish. Yeah. So I say, Umrish, hey, listen, we're making this blood pressure medication change. I want you to send me some blood pressure measurements over the next few weeks. You know, every week just send me a few measurements. That's requested data. I'm expecting it, and I know what to do with that. Another example. What's your name? Matt. Matt decides that it'd be a really cool idea to send me every day all of his activity information. Okay? Very different examples, right? One I'm requesting, one I'm not. And let's say instead of activity data, let's suppose it's your blood pressure data. Okay? What happens if I'm not expecting it? Right? And what happens if there's some elevated blood pressure measurements or very low blood pressure measurements? Who's monitoring that stuff? So that's another issue too. There's physician monitoring, who monitors it within the practice. There are liability issues to think about, pre-processing and filtering of the data. So if you send me your activity information totally unfiltered, right? I don't want that. But if I have a system that's looking through this, and finding trends and identifying things that are important, that might be more useful to me. How do we incorporate that into the record, accuracy of the data, and follow-up testing? So that's what we often don't think about. So an engineer, I talk to engineers all the time, work with them, okay? Engineers' view of the world is more data is always better, okay? But if you're a doctor, the nuance there is not quite true, because the problem is in biology, unless it's perfect data, more biology and more information is not always big because you get false positives. You get things that need follow-up. And the follow-up, by the way, is going to fall to the physicians, right? We got to follow up. We may have to do expensive or painful things, do risky things to you in order to get more data, even though you shouldn't have had that testing in the first place, perhaps. And then there's patient anxiety when they get data. You may be doing this and you're gathering the data and you say, oh my God, I'm kind of stressed out. And this happens all the time to me in my practice. Patients get their data at home and they're freaked out. They say, oh my God, my blood pressure, ah. Okay. So these areas are areas where informatics is really important, okay? Probably more of them too, but I highlighted a few things. So looking at the different data types, how do we acquire them? Looking at how we pre-process and filter that data. This is a really good informatics issue, right? How do we identify these trends and the outliers and so on? Really good science questions there. Incorporation into the record, probably I would have highlighted, except now we actually have technology to do that. We have the FHIR standard that allows that to happen. We just don't have policies that healthcare organizations practices that allow that to be uploaded most of the time. All right. I would say to you that since we're moving to that upper right-hand quadrant, we're doing things like telehealth and remote care of various kinds, whether it's synchronous or asynchronous. We need this stuff more than ever before. Because how can I have a follow-up with you and just ask you questions and look at you on the screen, for example, and not have any data? I need some data so I can make decisions. A lot of what we do as doctors is we're looking at data, looking at dashboards of data. All right, next topic. Technology tools support collaboration. What do I mean by that? Well, think about the Google suite of applications, all the things you use when you're collaborating using Google. Or you're using Microsoft Teams. I don't know what you guys use here. What do you use? Teams? Yeah. Sorry about that. Yeah, Beth Israel Deaconess does too, and I hate it. But that's Teams. And then there's Slack, which the cool people use. Okay, Slack is great too. The point is they're all important tools for collaboration. And then there's Hive and all kinds of other platforms. So, well, we're talking about healthcare, right? So we're talking about healthcare collaboration between the patient and the healthcare professional. Well, we have a collaboration platform there too. It's the patient portal. Okay, this is my chart. It's not an advertisement for my chart, but my chart is the best example. So I helped develop one of the nation's first patient portals back, I won't even tell you how long ago it was, but this went live, and this is called Patient Site. And so what do I mean that this is a collaboration platform? Well, this is the URL for it. You don't need that. What are the elements? What makes it a collaboration platform? And this is any patient portal. So first of all, it has messaging. Messaging, it's secure, it's automatically routed to people who can best take care of it, and it can be, you can assign tasks. Next, it has services. Remember we talked about those online services and reducing friction and so on. So patients get prescription refills, make their appointments, see their, get referrals and view their bill. And then there's education. People can search for information. They can be prescribed information by their healthcare professional, right? Patients can search through selected links and so on. But the coolest thing is getting to this type 2 information, which is that patients can see their records online through patient portals. In a secure way, they can look at their record. They can look at all their system records, upcoming appointments, medications, problems, and their notes now too. There's a whole lot to talk about with patient portals that I won't be able to talk about today, but this is really exciting. The fact that patients actually have information, detailed information about their own health. In our institution, we tell patients, before you come for your next visit, review the notes from your recent visits so you can talk about those things, okay? I ask my patients to do that all the time. So here are the elements of collaboration we talked about, or the elements that patients need to be engaged in their health, and we're hitting on all of them through this collaboration platform, right? It's information, it's communication, it's convenience. All right, the impact of a tool like this is extraordinary. So after we went live with this, my patients were all using the patient portal, I sent a message asking them, just tell me what you think about this platform in general, and what does it mean to you? And so one person, this was actually the guy who later became my collaborator, ePatient Dave, he sent this message: this is too cool. It's almost silly that things can be this easy. I am having a very good patient/customer experience so far. So it was great that he loved it, but the important thing is that what was important to him is that all of a sudden he was treated like a customer. He said, look, I'm in my 50s. I've been in the healthcare system for over 50 years, and never have I been treated like a customer where people are trying to make it easier for me to do things. So that was important for him. On the other hand, this is a guy, although only 61, retired minister, who was crippled with some kind of weird chronic pain syndrome, used a walker and so on. He said, I have a lot of medical issues. This system has left me feeling comfortable and in good hands. Otherwise, I would feel as cold, depleted, and alone as the lifeless tree in my front yard in the deepest of winter. I'm in Boston, remember? Winters are bad. So that had a huge affective importance to him. This was a lifeline for him, really. So the next area I want to talk about is helping patients decide and act. Okay? So decision aids for patients in the context of patient care. So anybody who's been through Bill's teaching understands that there's such a thing as clinical decision support, which helps healthcare professionals take better care of patients, right, using the information. And he and I have built lots of systems that do that kind of stuff. And that's important. But also important are tools that we can use with patients, where we turn the screen to them, and there's a way that patients can engage in this conversation as well. So that's important, and that's an informatics project. Patient-facing clinical decision support is another one. So tools that patients can use on their own. Now, it could be, let's say we're going to have a breast cancer screening conversation with a woman who's in her 40s. I might say, okay, I'm going to turn the screen to you, and we're going to launch this program, and you're going to go through this interactive tool. Okay, that's one way to do it. But the other way to do it is at home, right? There's a 50-year-old man, and I want to teach him about prostate cancer screening and help him come to a decision about whether to have a PSA test. Do this at home before you come in, and then we can talk about the results. Okay, so patient-facing clinical decision support, another important informatics thing. And then allowing patients to, and sending alerts to patients. So does anyone find it really bizarre that the patient, so we're, as healthcare professionals, we're getting alerts about things. Oh, so-and-so is due for a mammogram, this person is due for a pneumococcal vaccine, whatever, all these things. But we only get them when the patient's in the room with us or when we actually look at their record. But why is it that we just don't send these things directly to our patients, right? And next, allow them to take action on those things. Again, these are informatics projects, and we can create these interventions and we can study them. AI. I have to talk about AI, right? We're here talking about technology. So what about AI in participatory medicine? Well, this can help patients search for and interpret health information that they find. Because there's all these health information websites, right? If we can trust the AI agents, we can create a dedicated AI to do it, and they're not going to do these weird hallucinations, which are really confabulations, right? But then it can really help patients understand the morass of information that's out there. But in addition, it can help them understand and interpret their test results and the medical notes. So we've given patients access to the whole medical record, but how do they understand what's there? Somebody's still going to help them understand that. And that's where I think AI can play an important role. Automated first-tier responses to patient messages on a patient portal. Most doctors in this country are fed up with messages, not that many of them liked it in the first place, but they don't want more messages from patients because those got a lot worse during the pandemic, and we've got to figure out ways to help them with that. And one way we can do this is by hiring people in the practice to answer messages, but we could maybe come before that, before we get to the human personnel, which are expensive, we could create AI agents who can do this. That can do this, I shouldn't say who. We can facilitate convenience transactions, let patients know, oh, we think you're due for an appointment with so-and-so. Do you want me to make this appointment for you? Why can't we have those kind of Amazon-like agents, right, that can do these things for us? And self-monitoring of their health information from all sources. So all of us have information in different places. I've got a medical record at my cardiologist's office. I got one at my primary care doctor's office. I got the pharmacy record. I got my health data from Apple Health. All this stuff. Why can't I have an agent that's continuously monitoring this and giving me suggestions and letting me know when I should seek care? Now, admittedly, we don't have such things for the healthcare professionals either, but patients need this also. All right, so it's collaboration with patients. So these are some of the informatics things that I think that we can do to support participatory healthcare. So the collaboration leads to benefits, leads to reduced costs, improved satisfaction, and better outcomes, so that we achieve what has been called the triple aim. I don't know if you've heard that term before, but that is the triple aim. And because it actually can improve satisfaction for both patients and physicians, it helps us achieve what has been called the quadruple aim. One of my mentors, and someone that, a colleague of Bill and mine, Warner Slack, who's since been deceased, Warner wrote, "The largest and least utilized healthcare resource is the patient." Now, what's interesting about this is that Warner wrote this in 1976. And in fact, Warner did his first informatics work at the University of Wisconsin in the 60s, where he sat patients down in front of a computer to get a medical history. In the 60s, right? So he's definitely a friend and mentor. He really inspired me in a lot of my work. So I'm winding down here. You know, we mentioned the Society for Participatory Medicine. We work in a lot of different areas. We invite you to check us out, join us, whatever. Participatory medicine is a movement in which patients and healthcare professionals actively collaborate and encourage one another. So there's this mutuality to it. It's not just about patient power. It's about the patients and the healthcare professionals, and each of us pushing the other to be on our A games as full partners in healthcare. And I'm going to just flip through this real quickly because I've outlined the important areas. We have a manifesto, a set of core principles, and since I can't read it on the screen there, and this came out of work that we did at conferences where we actually brought a lot of people together to discuss what these things were. And the principles are sharing and listening, respect one another, share information responsibly, promote curiosity, and be a team builder. So bringing this back to informatics for a second. I don't know how many of you work in networking or access or anything like this, but there's this concept called the last mile. And when you're talking about networking and telecommunications, okay, what the last mile means is that you have to sort of deal with all this infrastructure over here, the backbone of the internet or the telecommunication network. And then there's sort of the middle mile, which is the fiber transport and so on that's connecting this to this. But the hardest part is getting this into patients' homes. Okay, getting patients into right patients' homes. And that is called the last mile. And that's kind of what participatory medicine is. It's really, you know, there's some things we can control and some things we can't control. But when patients enter the healthcare system, that's what we do. So we have a changing nature of the relationship. We're moving from information asymmetry to information symmetry. We're moving from patients being passive recipients of healthcare to being active partners. We're moving from paternalism to participation. And finally, we're moving from being a patient-physician relationship to also being a consumer-provider relationship. So to summarize, I think despite the challenges we have in healthcare today, we have huge opportunities. So number one, reimagining patient care as a collaboration can help us transform our healthcare system with the patient at the center. Number two, medical informatics provides technology tools and innovations that support this important transformation. I thank you for your attention. I welcome your questions from the audience members virtually and in the room, and I'm happy to communicate with you outside as well. Thanks. How do we get people to?
Yeah, so let me just ask, since we can't really see the chat real well, I don't know if anything's typed there, but people.
How do I do that? Is there something I need to do?
No, but people can just unmute themselves and ask any questions that they have. I know we're about at the hour, but we have a few minutes for questions.
By the way, this is a book down in the lower left-hand corner, Let Patients Help, a short book that Dave and I wrote together. All right, I'm going to end that and take this out so we can.
I see that Kate has turned her video on, but she's
You
still
know, I
muted.
have
Oh,
to ask a
Hi,
question.
Kate.
I have to ask a
Wait, I want to stand over
question.
here so I can see you. Hey, you can't see
Hey.
me, I guess, huh?
I can
Yeah,
see
it's
you.
me.
Thank
Okay.
thank you for your wonderful talk, Danny. It reminds me, all the troubles with technology reminds me of the time when I followed you in Grand Rounds and people were asking you how to fix their pager. So that was really good. The question I have is the one that I care about is education, the education of the patient, education of the doctor. So how do you balance this out? You know, some patients really do want to be the know-it-all, and they don't have the education, for example, that you've had. So how would you, it's kind of like what I've been thinking a lot about in terms of, you know, who has the education in order to provide the advice?
Yeah, so the question Kate asked is an interesting one, which is about, you know, patients who just sort of feel like they know everything and they don't understand the fact that you have expertise there too. And I think that, you know, this is why at the society, at least, we kind of focus on educating patients as well as educating physicians. In fact, just to put another plug in, on Friday, when we have this creative learning exchange here at the Robertson Life Sciences Center, you know, we will have patients in the room as well as healthcare professionals. Okay, and what we need to convey is this idea that yes, the doctor is, or I don't want to say doctor, the healthcare professional is an expert in healthcare and in their area of medicine, but the patient is an expert in themselves, in their own symptoms, in their own body. And I think it's not that we have to stick to our swim lanes, it's about learning how to dance. Maybe that's a better way to put it. And there's always going to be friction because, you know, as you said, some patients are not okay with that and they don't respect, you know, any of the education that we have, education experience and so on. But on the other hand, the same thing is true in the opposite way too, which is that we often don't respect what the patients bring to the table. So this is like learning to dance. And another one of my mentors, Tom Delbanco, uses that expression, which I think is a good one. It's learning to dance, and we're not always going to quite get it right, but we've got to continue to work at it. And I think to the extent that we can educate healthcare professionals early in their education, and we can educate patients before they need to be patients, when they're in middle school, that's what we really want to do. So I know it's not a perfect answer. I don't have all the answers there.
No,
this
no,
is
no,
always
no,
a
no.
tension.
Yeah.
I still have tension with my patients sometimes too.
Great.
Thanks for your question, Kate.
Any other questions?
I will also mention that Faraz, who's on the WebEx here, is the MC for our event on Friday. And thank you, Faraz, for doing that.
Of course.
Any other questions or comments?
Hi, this is Karen Eden. And
Hi, Karen.
hi. So one of the projects we have going right now is that we send a message to patients inviting them to use our breast cancer screening risk tool and to send it through MyChart. So we send it through the portal. And the clinicians have been very supportive of this idea, but one of the challenges we had was figuring out a way to succinctly bring the information back to the clinician in some kind of note. And I noticed the importance of patient-generated data. So we don't want to overwhelm the clinician with information, but do you have any ideas about how we can provide that in a way that is concise and succinct, but lets the clinician know more about self-care and the things that they're doing?
Yeah, thanks for the question, Karen. I think that's a really important project you're doing, and I know that there's a researcher, Maura Schoenberg, in my division at Beth Israel Deaconess, who's also involved in a project like that. At any rate, yeah, I think that the way that I would think about that is ideally, and again, you may be limited by the technology, but I think at the very least, there should be a note. So a note that comes out of that goes into the record, that summarizes the results of this decision support tool that the patients went through. And then you may need to let clinicians know that that note exists. Now, ideally, that note is an interactive note, not just a PDF document. So the next stage would be to make it interactive so the doctor could click on something and see a dashboard that shows them why the patient came out this way. So I think that's probably the way to do it, but of course, we don't want to have doctors have to log into a different website or something to get that information. Thanks for the question,
Right.
Karen.
No, I agree. Thank you so much. Great presentation.
Thank you, Karen.
Great. Well, we're at about an hour.
Okay.
So, I think and people may have other meetings. So, thank you again, Danny, for, enlightening us with your talk, and, it was a great discussion.
Thank you. Thank you. Feel free to email me later if you have any other questions or comments. And come on Friday.
Yeah, that's right.
Is that on camera?